Good morning, everyone. Welcome to the Department of Medicine Grand Rounds. Today's CME code is 31645. All right, it's truly a pleasure for me to introduce today's Grand Round speaker, Dr. Sanjay Desai. Sanjay is a graduate of Harvard Medical School, and then following that went to Johns Hopkins, where he did his internal medicine residency, chief residency, and pulmonary and critical care fellowship. For over 10 years, Sanjay was the program director at Johns Hopkins in the medicine residency, the country's first residency program and one of the most influential. And for the last 5 years, Sanjay's been at the American Medical Association, where he's been the chief academic officer, where he's had a lot of roles, but overseeing educational innovation, policy, as well as a grant portfolio of almost $40 million. I promised him I would highlight this. Sanjay is currently unemployed, so he has just finished his tenure at the AMA, but in about a week from now, he's going back to Hopkins as the Vice Dean for Education at the School of Medicine. So he'll be overseeing learners from medical students all the way up through practicing physicians. Sanjay, he's a nationally recognized leader in medical education. This short introduction certainly won't do him justice, but I'll give a few highlights. So Sanjay chaired the executive committee of the iCompare study. This was a landmark trial looking at duty hours in GME and patient outcomes that led to a series of publications in the New England Journal of Medicine. Sanjay has also led pretty wide-scale efforts rethinking how we train physicians, with a particular focus on clinical skill as well as physician well-being. I think one of the things that's harder to capture on a CV, but I think is just as important, is the impact that Sanjay's had on people. So I first met Sanjay probably about a decade ago now, when I was on the interview trail looking for residency programs. Sanjay was my program director for 3 years, also for part of my chief year. And since that time, he's remained a very close friend and mentor. I think one of the things that has stuck with me and the influence that Sanjay has had on me personally and many others is really a passion for medical education and a desire to be involved at levels of medical education, such as program leadership. In full transparency, Sanjay is also one of the main reasons that I'm here at Robert Wood. So if you're looking for someone to blame, look no further than Sanjay. So with that, I will welcome Sanjay up. He'll be talking today about precision education.
Thank you. It's really an honor to be here. So I want to thank Brian and Jean and Pyle for inviting me. And last night, Pyle asked at dinner, I've had several roles now. Which role is the most meaningful or the most gratifying? It without question, was the program director role. And I think it's to work with all of you and to work with Brian and people like Brian. And that, for me, for sure, is the most satisfying experience I've had professionally. So thank you again for having me. All right, so jumping into precision education. So and as I'm unemployed, as Brian said, but it feels actually really pleasant to not have a job, knowing that you have a job coming up very soon. So that feels quite comfortable right now. But my disclosures are really none right now. These are my opinions that I'm going to be sharing, and I have lots and lots of acknowledgments that I'll sprinkle throughout the presentation. I'll try to stay close to this microphone as well. So these are objectives. So why is our lifelong model right now, learning model right now, not ideal? What's a way to improve it? And that's precision education. And then most of the time I'll try to talk about some illustrative examples of how this is happening already. I mean, and much of this is centered on AI. So I'll just say at the outset that this talk is, many of the examples I have are probably 6 months to 1 year old. And that's ancient, honestly, in terms of the speed of AI. If you think about how industries are changing literally under our feet, probably the most vivid example I have is with coding. If you have colleagues who are computer scientists, they'll explain that in February, when Anthropic came out with Opus, what is it, 6.4, I think was the last one, people do not code anymore, they orchestrate coding. So it literally, 3 months ago, everything has completely shifted an industry that we think about every single day. So this is not the future, this is literally under our feet. And so hopefully that will come across, and the urgency I think that we should be feeling will come across as well. But why do we do this? So trying to describe, and hopefully this will resonate with all of you who are going through this system now, but ideally you have a system in which, in the US model, you have medical school, obviously residency and fellowship, where at every stage of learning there are entry gates that ideally are meant to be fair and equitable, that bring people in and recruit people, promote people, and develop people in a way that is best for them and best for their competency. And if that's true, then your competency just grows continuously as you go through this system. And we know that this is not how it actually operationalizes in real life. And so if you take this clinician here as an example, let's imagine she's a second-year pediatric resident, and she's on the wards, and she admits a baby who is deteriorating rapidly from infection with RSV. And so if this was true, then she should feel comfortable taking care of a patient with a common condition like that and deteriorating in a way that she should be able to manage as a second-year resident, but she's not comfortable. And she's not comfortable for many, many reasons. And part of that is that we have randomness in our system. So through medical school, she may not have been in a clerkship during the winter when RSV was more prominent, so she missed out on seeing RSV, patients with RSV at that time. She doesn't feel comfortable, as you can see here, in patients with respiratory distress, because when she was in the ICU as a medical student or even as an intern, she didn't see enough of that particular condition. She didn't feel comfortable explaining to the mother what was happening, and that's because her attending, when she was an intern, chose to do all the family meetings on their own just to help the team save time and do the work that was necessary. You get the point. There's a lot of randomness in the system that depends not on what you know and what you need to learn, but based on external variables. The easiest example actually as program director, and I don't know if it's the same file for you, but we didn't create residency rotations based on what we know people should learn, mostly because we didn't know what they needed to learn, but it was mostly based on their vacation preferences, which are really important to people, but that does not help us develop competency in the way that we wish to develop it. And there's also this one size fits all. Everybody that comes into medical school goes through the same classwork. They could have been a biochemistry major or a humanities major. We know they enter that space with different skills and different learning frontiers, yet we put them through the same model. So this particular clinician, you can see, didn't follow that idealized path, and it looks more like this, where there's undulations. Because of this randomness, there's points where your competency is not accelerating, but your development is actually decelerating during that time, and that's not efficient. There's also, you can see here at the point between medical school and residency, a plateau. These plateaus can occur anywhere, but they typically occur between stages of learning because we're not able to transfer what we know about somebody's competency profile to that next stage. Sometimes because we don't know what it is, because we haven't measured it accurately, but often because we just don't know how to transfer that information to the next stage. And that when that happens, you enter that next stage and you kind of start all over again. And that's, again, leads to plateaus, which is also inefficient. But in addition to these undulations and these plateaus, there's a lot of variability in the journeys that all of us, and I imagine all of you, have experienced as you go through this model. And so I'm going to go through a few archetypes here, and you'll hopefully, again, recognize some of them. So the first is this classroom achiever. This is the person that in these early stages of learning does really well, excels, achieves above where we would expect them to be, and then they go to the clinical setting and they're not really excelling at the same pace. This is a common archetype of the learner that goes to the medical model. Then there's the opposite of that, the late bloomer. This is the person that isn't thriving in those standardized models and standardized evaluations that we use in those early structured environments, but they enter the bedside and it is magical. And I will tell you that this one we see regularly, which is quite scary because who are we missing in this model when we're actually selecting for those that move on in the model? There's this stagnating learner. So this person's not really achieving where we expect them to be achieving, but it's really hard because we're not resourced to help bring them up. And the easiest path there is to push them forward. This is really common in K through 12, as I'm sure you have heard or maybe observed. And the problem with this is that you get further and further along, you get much more distance between you and where we want you to be as a learner in terms of competency. There are those, unfortunately, that are unsupported, find themselves unsupported in the training environment in which they're immersed. And that leads to a plateau at the very least, but unfortunately, it leads to people exiting the pathway altogether. this can happen. I've highlighted it here, medical school and residency, but you can know it can happen at any point along the way. And the last one I'll share here is just the one that is also unsupported, but unsupported in practice. So this is quite common. Those that go through all of the structured environments that we have, but then enter independent practice and find themselves in an environment that doesn't facilitate lifelong learning. And then it gets really hard because the world changes, biomedical knowledge increases, and to remain competent is harder and harder. So the problem here is not just the variability in journey. The problem is that this leads to variability in competency achievement. And this is what I believe we need to fix in our lifelong learning model. And so how might we do that? I just highlight this because in addition to these variable journeys, you superimpose that upon where we are today, where biomedical information and medical knowledge is doubling incredibly fast. And so this is 2020 data, 73 days. I've heard recently it's under 40 days. And I don't know if that's true or not true, but we know that it's incredibly fast in terms of the advances in biomedical knowledge. So how do the knowledge base is expanding, there's variability in journey, so how might we fix this? And this is the why. Why do we need to fix this? And I'm going to highlight 4 ways that we could think about fixing this. And these are 4 different strategies that have been used or addressed or at least thought about for quite some time. The first one is competency-based medical education. This is a strategy that has been thought about for decades. And the reason it hasn't been implemented effectively is because it's really hard to implement. But imagine if you can assess competency at every step along the way, then you're able to continue to push people up to where you want them to be. And if you can do that, you can increase the slope and reduce variability. But it's hard to assess people with the granularity and the reliability that you need to be able to do this effectively. The second is to improve these plateaus. So if you're able to improve these transitions between stages and transfer data more effectively, then you can actually start to reduce these plateaus and again, increase the slope of competency. If you can embed equity, so we mentioned some people find themselves in environments where they're not actually recruited and developed and promoted in a way that is most supportive for them. If you can improve that, then you can start to increase these slopes as well. And this is fix the pipes is an analogy people use about water in your house. And if you have a water leak, it's not appropriate to focus on the water. The most effective thing is to focus on the pipes through which that water flows, and that's how we're going to make the most durable system that we can. And the last one is to increase personalization. So as I mentioned, there's randomness and one-size-fits-all approaches that we typically will use, inflexible approaches, and that leads to moments of acceleration in your development, but it also, I think, as all of you hopefully, or not hopefully, but probably have experienced, moments of deceleration. So if we can personalize and bring the right education to the right person at the right time, we can reduce these undulations, and that again increases the slope. So if we do that, you can get from these variable journeys to a much more narrow scope of competency development. And this is not reducing the variability of what people can do, it just reduces the variability of the competency that we expect people to achieve. So it's an important distinction because we want people to have different interests and have different skills, but we want them all to have a threshold of competency that the public expects us to have after going through this decade of education and into independent practice. So if that's the goal of achieving that more reliable competency achievement, how might we do that? And this gets into the idea of precision education. So we thought about this starting about 4 years ago. There's been conversation about this for a long time, and this was all based on data and technology historically, and obviously now it leans heavily and really centers on AI. But we brought together a variety of industries and experts from different parts of the country to help us think about how you might improve the model and reduce those barriers that we just talked about. And this is us talking with Sal Khan, who's been a colleague that's been very supportive of our work and someone that I consider a visionary in precision education. He again focuses on K through 12, but he really believes in this idea of competency-based rather than time-based models of education. And he's been a great advisor for us as we thought about these models. And that led to a conceptual model that we published a couple of years ago on precision education, which is basically the idea of taking data and technology and leveraging that to do 3 things. To make sure that we can somehow personalize our education, again, right education, the right person at the right time, to make it more efficient. We know learning is in itself inefficient. There is friction in learning, and there should be, but there's unnecessary friction. So how you might eliminate some of that unnecessary friction. And the last is to give agency back to the learner. So our model largely gives agency to the institutions that educate you. And so the medical school decides what you're going to learn when. When you're on clinical rotations in GME, it's not up to you what you see. It's often up to the attending what you're going to be taught, or the residents what you're going to be taught if you're junior to them. So if you have, and the easiest example of this is a dashboard. If you're able to know what you know and what you've seen, then you can direct your own learning a little bit more effectively. And so agency is very important in this as well. And the last feature of this is that this can happen at an individual level. So we can create personalized learning for you. You can also create data, leverage data to create insights about a program, and this could be for a program director, and you can also do it for an entire institution. And I'll give you examples of each of those as we go through them. So this is the model that we have, and I'm not going to go through this in great detail, but the idea here is that about every single person that enters this path of becoming a physician, there are tremendous amounts of data that are collected about you. Now, the data, as you can see in the center of this model, are held in fragmented systems and dispersed across the country and across different platforms. So you can imagine they're in your learning management system, they're in your electronic medical record, they're in the health system, they're in government agencies, they're in payer databases. So there's an enormous and abundant amount of data about each of us that is continuously collected. And the opportunity here is if you're able to aggregate those data, then that can create inputs. If you look at 10 o'clock on this chart here. Those data collected are inputs into this precision education systems, and then you perform analytics on those inputs. You can create insights. From those insights, you plan for interventions. You deliver those interventions, learning occurs, you assess that learning and understand what the outcomes of that is, and then obviously adjust and continue to go. This is obviously built off of the Master Adaptive Learner model or the PDSA model that many of you are familiar with. And then you can think about AI. So this model was developed before ChatGPT was published by OpenAI. And then if you think about now all the advances with AI that have been added, this just simply supercharges this entire cycle. So you can see you can create far more sophisticated insights. You can do this in real time. This is a really important one. You can do it tirelessly and consistently. So these models can never fatigue. And you've probably read about this when they think about giving empathetic responses back through the electronic medical record. Again, there's just no fatigue associated with these models. It's all automated, and it finds from these tremendous amounts of abundant data the signal that we can't possibly perceive because it's imperceptible to humans, that we can help drive personalized learning. So this is the model. If we're able to do this, then you can imagine going back to this pediatrician that's a second-year resident, a model where we use that a system of precision education that can leverage data and technology and help her not be in the position that she's in. And so this is, I know a lot of writing here, so I'm just going to highlight a couple of things. But imagine that this pediatrician in medical school was immersed in a model where there's precision education learning. So that you'd identify that as a person that wants to go to pediatrics, she didn't do her rotation in pediatrics during a certain season, and she, because you can match this in the EMR, hasn't seen patients with RSV, so you could create simulation, extra rotations. You could notice that she has, as she transfers into residency, where her gaps particularly are, and that residency can then adjust what she's onboarded with. Maybe by the rotation that she's on or by supervision that she has, you can create opportunities to learn communication more effectively. Imagine she has an AI coach, an AI tutor where she can interact before the family meeting and practice what she's going to say to make sure she's delivering it accurately and empathetically. So there's a whole host of things that you could do that she could drive herself to ensure that she's not in the position that she found herself in before we have precision education systems. So this may feel far-fetched or futuristic, and as I mentioned before, the world is shifting literally under our feet, and it's not. So these things are happening now, and I'll give you a few examples of them. And this is the last section of this, is how is this happening? It's happening all over the place. So these are different examples or domains of where precision education capabilities are emerging. And probably you've seen many of these, and again, I'm going to only highlight a few different examples. And I want to stress again that this is, what I will show you is 6 months old, maybe a year old, and it is occurring and developing much, much faster than I'm describing now even. So the examples that I'll share, I'll contextualize in the setting of a problem statement and how you might try to address that problem. Hopefully for people in the room, these problems are ones that you can you can notice that you may have. So how do you systematically assess clinical reasoning? This is a really hard one. In fact, Brian spends a lot of time thinking about clinical reasoning and how we might develop it. But to develop it, we have to learn how to assess it. And what has been inefficient and unreliable is having a faculty member individually go around and assess clinical reasoning from each individual person. So how might we take advantage of the abundant data that we just described exists in our systems to help us assess clinical reasoning of our trainees? And so one way to do that is to look at clinical notes. And this is all, what I'm sharing is pre-ambient, and now with ambient, it's only gotten more impressive, I will say. So the idea here is that this was done, you can see I didn't have all the reference or all the acknowledgments, but I try to include them on all of the slides I have here. So these are some of the leaders of this work. There are many more people involved. And what they did is they took notes from, this is internal medicine residents, and they had experts, like those in the room in the front that I see here, review those notes and come up with a rubric of what is a high quality note and what is a low quality note. And they had a standardized way of assessing that. Again, it's impossible for people to continue to do that because the resource you don't have for us to do that individually. But you create an algorithm for this, and then you deploy that against the EMR, and then you can literally tirelessly, continuously assess clinical reasoning in notes. And if you're able to do that, you can generate these really fun visualizations of data. So what you'll see here are the data from, you can see here, almost 30,000 patients, 40,000 notes that were assessed. And on the y-axis is the density of notes, and on the x-axis is the quality of those notes. So the further you get to the right, the more high quality it is. The further it is to the left, the less high quality it is. And you'll see that this program had, this institution, sponsoring institution, had 2 internal medicine residency programs. And so there's a lot of insights I think you can gain just from this high level. This is obviously an aggregated view of these data. First thing you can see is that there's a distribution, which you would expect, of low quality and high quality notes. So that in itself would be informative, because as a program director, you can actually drill in and see who is where. And it may not be that one person is in one point all the time. It may be that it relates to other variables. But in either case, you can start to address why are these low quality notes low quality, and you can start to make interventions there. The second thing you can see is that there's differences between the 2 programs at the same sponsoring institution. And so that's an opportunity to improve program A to look more like program B. And again, finding the interventions or the reasons why that might be happening. But without the data visualization, it's not possible. And this is 30,000 notes. With ambient, as I mentioned, these can easily be 100,000 very, very quickly. So you get the data and you get to move it quickly as well. But then you get to get insights into things that we only think about and guess about once in a while. So this is quality of a note within hour of shift. So we think about how do you construct shifts for our internal medicine residents. And one of the attributes that or outcomes or variables you want to look at is the quality of notes as you do that, or the clinical reasoning as that goes on. You can see this is a night shift in black and a day shift in red. You can see it changes. Again, there's a lot of hypotheses you can make around why it changes and when it changes, but you can see that it changes through the hour shift. You can also see that based on the number of admissions that it changes as well. And so these data may help you decide how to structure your admission windows. It may help you structure when more supervision is needed. It may help you structure how many admissions and when admissions are handed off. But again, without these data, we make our best guess. And so this is an opportunity to improve that and to address people, not just at a program level, but at an individual level as well. The second thing is patient relevant learning. So this is one that I think is we get stuck on often. So we often want to teach and we want to make sure people are learning effectively, but how do we create learning that is relevant for the patients that you'll be seeing? And so this is an opportunity for us to create nudges. And this work was done primarily at NYU. And this, what I'll share with you right now, is being done for medical students, but it's already being done now for residents as well, at more than just NYU. And what they did was they took medical students and they have them during their internal medicine clerkship, they would, as the medical student typed in their note, the natural language processing system that they had would pick up the diagnosis that they believe the student is thinking about with the patient that's being admitted. And then based on that diagnosis, they would do a bunch of stuff to help teach that student in real time. So the first thing they would do is they pick up the note. This patient, as an example, was someone that was admitted with the condition of cirrhosis from alcoholic hepatitis. And they can see that this is the third admission that this student had. And then what it does, it feeds to this student at, let's say, 2 o'clock in the morning. It curates from the online resources that NYU has. It looks through all of those. It looks at the diagnosis that it thinks the student is admitting. And then it sends to the student not just the chapters, but actually within those chapters, the areas of those chapters that are relevant for this particular patient that they're admitting. So the idea here is just-in-time patient-relevant learning. So I think students want to learn like this, but it's really hard at 2 in the morning to know, how do I scan all of the resources at this institution and find the specific things that I need? That takes a lot of time and a lot of resource, and it's late and you have to present soon. So this makes it easy. It reduces unnecessary friction in the system, and it makes it more effective for people. So this is what happens at 2 o'clock in the morning. Then they get an email that actually digests all of this and actually synthesizes some of those data as well. So it actually produces a synthesis of what they think the student could benefit most from learning. And it knows what the students read before or learned before, and it can make it sophisticated and, again, personalized for this particular student. And when this happened, they asked the students afterwards how they felt about it. And just highlighting in the purple boxes here, so they thought it was timely, they thought it was relevant. But the one on the right, I think, is the most important one for me, which they thought it was fun. And I think if you think back to when we all applied to medical school, it's hard to find a group of people that are more excited to learn and that are more curious, and it gets harder and harder to feel that way as you go through. And that's not the person, that's the system. And so that's what this did again. This made it fun for them because they want to get these information, but it's really hard sometimes to access it. So again, as I mentioned, this has been accelerated to GME as well. So you can imagine when you're admitting somebody in the ICU, you can get these types of information that are personalized to your level of learning when you need to learn it, and be ready to think about it and present it. This is work that Brian was involved with. So this is something we think about all the time. How do we make sure that you, as this is all in GME, are in an environment that is going to promote your clinical skill and promote your well-being? And this is something we think about all the time, but how do we have data to actually assess this? And this is another opportunity to use technology to understand this. And there's a lot of hypotheses around where you spend the time, how much time you spend with patients, and if that improves your clinical skill and your well-being. So this work was done at 3 institutions that you can see here, along with the Society of Bedside Medicine. And what we did is we took internal medicine residents, and we recognize that there's a way to technologically see where people are. So historically, the way that you see where people are, how much time they spend with the patient, is by taking medical students and having them follow them around. And we did that. Brian mentioned the iCompare trial. We did that. That was the largest time motion study done in medicine. And it was extremely expensive, extremely high resource. And in the end, we had 2,000 hours of observation time, 2,000 hours. With this, what we did is we put trackers on people. These are the same trackers that you may have on high capital equipment like an ultrasound machine. And there's sensors all across the hospital, so you can track where these things are. So we put these on residents, and it would track where residents are anywhere, and it's every 3 feet, so you know exactly where they are in the hospital. So you can measure with a high frequency of ascertainment the location of people in the hospital. So as I mentioned, iCompare had 2,000 hours, largest study observation for time motion. This, in 3 months, had 100,000 hours of observation and was completely effortless to do. So with that, you get this, again, abundant data set to see where people are and how that correlates to clinical skill, because there's a rigorous clinical skills assessment, and then how it correlates to well-being, because all of these residents also, every 2 weeks, we're doing well-being assessments, 2-question well-being assessments. So you can see if there are associations here or not. And let's see what I showed here. So this is the first, this is an example of data that you can get. So the first, these are every single resident that was shown. You can see, first of all, that there's a high variability between the amount of time spent at bedside. So the average was 13%, which is the same as the time motion studies that were done before. But you can see the lowest was 9%, the highest was 18%, so double the amount of time. So there's opportunity here to move it. So without these data, you wouldn't know that. The second thing, you can actually see when they're spending, which rotations they're spending more time with patients and which ones they're not. And you can see whether it's based on the rotation or is it based on the physical environment, or is it based on the attending? You can actually map it to attending schedules as well. So you can start, if you believe the hypothesis that if you spend more time at bedside, that's a good thing, then you can start to make interventions toward that. Now you can say the hypothesis could be opposite, that if you're spending a lot of time with patients, maybe your clinical skill isn't that good because you need more time to collect that data. You're not as efficient or effective at it. So again, these are testable hypotheses that are important for us to know so you can start to change the environment in which we practice. And by the way, that's particularly important, just my own experience, and I think, again, this is something Dr. Broderick and Jean will remember, is that we get calls from our hospital administrators to say, accelerate rounds today because the ER is backed up. So it's really hard to prioritize education, which is slower for sometimes patient care, in an academic medical center. And the levers that you need are these types of levers. You need levers to say that if we spend more time with our patients, that our residents have less burnout. If we spend more time with our patients, they have higher acceleration of developing clinical skill. Those are the types of data that I think are far more convincing than our anecdotes and emotions about why we need to do these things. And so I think these are important data for many different reasons. The other thing I do is we talked about agency. So we don't know what's right and wrong, but every resident that was in this trial gets a report like this, where they will see where their time is spent in comparison to where everybody else's time is spent. And again, we don't know what's right and wrong, but probably I would want to know if I'm 2 standard deviations away from the time profile of all of the colleagues that I have. And that may maybe reflect and think about what I would do differently in terms of the time where I spend my time as well. The last thing I'll say here, which I think is really interesting, and these are being these are in press but not published yet, are the associations between this and well-being. So what they looked at, again, there's hundreds and hundreds of thousands of hours. So as you can get hundreds and hundreds of thousands of hours of data, you can create these profiles of the person on call. So there's a profile, as you might imagine, of the person on call that is at the bedside predominantly. There's the profile of the person on call that's in front of a computer predominantly. There's the profile, there's 4. There's the profile of the person that they call just chaos, is literally all over the place. And you can't predict where they're going to be next. And then there's a 4th profile that is what they call inefficient, just in the hallway a lot or just walking a lot or whatever it might be, but not necessarily in any one of those places, but more predictable. And what they found is based on the correlation to their well-being surveys, the patient, the person in front that predominantly was with patients had statistically significantly higher well-being scores. The person that was predominantly in front of a computer has statistically significant, the lowest well-being scores. So again, these are the type of data I think we need to convince ourselves and administrators and our structures to change to move towards bedside medicine, which I know is a big compelling reason in and of itself, but the data will be helpful because there's a resource involved with that. All right, 4 out of 5. So clinical competency. And so this is a really interesting one that we used to spend a lot of time thinking about, is how we're all in team-based work. How do we possibly know the competency of an individual at a granular level on a specific condition in this team-based model? And this is called attribution. And so this is something we thought about for a very long time, more than a decade, probably 20 years at least. And people were thinking, okay, well, we could read notes and see, can we find in the note what this individual was thinking and then assess them. You can imagine the amount of resource that goes into this, and it's not possible to do, again, at a human level. It's also, even in the model that we have now, I can just speak for myself, that I round in an ICU. After spending time in an ICU, it's really hard to know what is this intern's capability in this specific condition. Because again, it's a team-based model, somebody else was her attending last week, and somebody else will be next week. So how do you gather all these data aggregated in a reliable way? So what they did was they thought about what is a clinical condition that's very common that we want to understand the competency of our individual trainees, and how might we measure it in a algorithmic way. And so they used diabetes. Patients are admitted with complications of diabetes all the time. And they said, okay, we're going to have a patient, whoever's admitted with a complication of diabetes, they took a set of experts And they decided, based on the best practices at that hospital, based on guidelines, what do we expect in terms of the insulin regimen? And what they looked at, something very specific, this is a proof of concept. They looked at something very specific, which is the combination, the ratio between short-acting and long-acting insulin for patients that come with a complication of diabetes that are insulin dependent. And they said, this is what we expect. This is best practice for us to have this ratio. And therefore, we want senior residents to hit this every time. We want junior residents to hit this X percent of time, and we expect interns to hit this at a lower percent of time. So they have a model. This is what we expect. This is what the ratio is. Let's see what happens. And then it basically runs. So then they have, whenever patients admitted with the complication of diabetes, the natural language processor would pick up that this patient has that particular condition. The EMR would then kick in this algorithm, and then you have to think about attribution. So who is making the decision on how to care for this patient? That's an individual team-based model. So they knew at their hospital on this team that whoever puts in the orders in that first 12 hours is the person that's actually making the clinical decision. That might not be true in every team and in every hospital. They knew that here. So the EMR, this algorithm, the AI engine that they had, would look at the orders that were put in, and it would determine who put in the plurality of orders for those first 12 hours, and it would make attribution. And it would know, is this a first-year resident, a second-year, or a third-year resident? And then it would look at the short-acting and long-acting insulin regimens that they ordered for that first 24 hours. And it would then compare that to what is expected for that specific level of trainee. And it would create this data visualization map on where you are compared to where we expect you to be. And it would do this every single time you admitted a patient with this condition. And again, impossible to do without technology. And once that's done, it would feed that data to this intern or resident's coach, clinical coach, and to the intern and resident themselves. So they would know, and they'd have a clinical coach that can help them interpret those data. And you can continue to improve this every single time you go through. And then for the program director, I'll show you the data that we get for the program director. So for the program director, they get a data plot like this, which is basically a 4x4 showing the ratios of short-acting, high-acting insulin. They have where they want them to be, which is right in the middle. And you get a plot that looks like this with every resident. So you can see a number of things here. You can see that there is variability, which we would expect. But you can also see who is in which of these different quadrants and and so you can start to look at this and say, well, are there systematic issues here? Because it may be that those that are in the outliers had a specific third-year resident that was part of their educational model predominantly, or maybe an attending, or maybe we need to increase our endocrinology rotation or endocrinology noon conference topics, whatever. You can imagine a whole host of interventions that could be designed to address whatever variability you find intolerable here, and you continue to follow this regularly because these are not data that are static, these are data that are dynamic. And so you can do this at an individual level, you can do this at a program level, and you can start to do this for other conditions, obviously, as well. The last one I'll share is procedural feedback. So some in the room probably remember see one, do one, teach one. Terrible idea. And then we move to, let's go to, if you do 5, you are magically competent in doing a central venous catheter. Terrible idea. We know that somebody here probably knows better than I do. It's like 50. I think at 50 is where you start to become proficient, right? Where your error rate starts to stabilize. And so this is not good. And so how might we make this better? And it's not good, and it's hard to fix in the model that we had. But how might we think of a precision education system that can make this better? And so the way to do that is work that Carla Pugh did. She's a trauma surgeon at Stanford, and she's been doing this in procedures of all sorts. So she did it with the vaginal exam, with the breast exam, and then she's done it with surgeries, which is what I'll share with you right now. And this is with scalable simulation and wearable technology. And this is accelerated, I can explain how it's accelerated as well, but I'll just give you an example of what she's done. So this is a cardiac surgery. This is a surgeon who has wires in their gloves and wires in their white coat or in their scrubs, and so you can see the motion of their arms and specifically motion of their hands. And you create these kind of visualizations where the left hand, you can see the 3D motion, on the right hand, you can see the 3D motion as well. And with these visual maps, you can create very interesting data. And so then you can follow people that are at different levels of training and see what their visual maps look like, and then based on that, understand how you might direct their development in a more personalized way. So this is a fellow on the top and a faculty on the bottom left hand and right hand, as you guys can see here. And I'm going to draw your attention to a few things that you can pick up on these types of wearable technology data. So if you look at the right hand and the fellow versus the faculty, I think hopefully you'll first see that there's a lot more splay in the fellow's visual map compared to the faculty's visual map. And so that in itself will just say that what Dr. P will say is that the fellow is being inefficient with their operating hand. This is their dominant hand. They're being inefficient. There's too much variation in their movement compared to the faculty member. Then you'll see on the left hand that the faculty member has more splay than the fellow. And so that's important also because it demonstrates that the faculty member is actually using their non-dominant hand in a more supportive role more effectively than the fellow is. And so what she'll describe is that this is completely imperceptible if you're standing across somebody at an operating table. You cannot identify this, or you can't help them get better at this. The other thing you'll see here is the color changes on the lines, and the color represents velocity. So green is fast, blue is slow. So you'll see on the right hand that there is blue in a certain area where there isn't in the fellow's graphic. And Dr. Pugh will explain this is the most critical portion of that particular surgery where she slows down. And the fellow is not. And again, she'll describe this as completely imperceptible. The thing that's even more imperceptible than this is not shown here, but they've added haptic technology to this. So you can actually measure pressure in addition to velocity and movement, which again, surgeons will have described to me that as being even more important than what you're seeing here. So this is the amount of pressure you're applying to these certain tissues. So these are things that you can't pick up, and it's far obviously more effective than C1, do, and teach one, or doing 5 of them. But you can scale this because it's collected every single time that they operate. And you can scale this even outside of clinical environment by doing it at conferences. So she's doing this at surgical conferences where there are simulated stations like this, and you can collect enough data to create learning profiles and thresholds so that you understand what is, and start to develop best practices for these particular surgeries, which we're not able to do before. Again, now they're adding haptic technology, they're adding Google Vision as well, so you can actually see in real time what you're doing. So these are all after the fact visuals that are being shown here, but if you have heads-up displays, you can actually see this while you're actually doing the procedures as well. And so all of these things are, we hope, going to make our ability to assess and develop people in procedural skills far more effective and efficient as well. So again, this is the conclusion. What if this works? As I mentioned, you go from this variability to an environment that hopefully is far more reliable in terms of competency. I'm just going to conclude with one more thing. What if it works too well? Because this is a concern that's been raised by many, and I think appropriately so. And you've probably seen some of these studies that show that the AI tools are better than humans. They perform better with empathy, they perform better with clinical reasoning, with triage, with a whole host of things. And this is, a lot of this is actually these data that I'm sharing here are also, some are more than a year old. And so you can imagine the speed with which this is going to get better as well. So what does that mean for what we do? And so I'll just, this is work that maybe some of you know, Leo Salih, who's at MIT. He's a critical care physician between MIT and Beth Israel. He spends all of his time thinking about AI and clinical education, clinical practice and clinical education. And I've adapted his comment here, which is this idea of a tool. So imagine AI engine as a tool. So currently that AI tool is better than a human. Those are the data that I just shared, and lots of those data are coming out. And then if you bring the human using the AI tool, the tool is still better, which means that we as humans are degrading the performance of these tools currently. And I think that's worrisome. So should we believe that this will continue, or do we believe that this will change? And I'm, as an optimist, and I believe this will change. I believe that these studies, if you look at them, they've been criticized heavily for the outcomes not being meaningful, or the fact that the physicians that have been using them are not trained in how to use them. So you can't imagine, so they would degrade the tool. They're not learning how to use this to augment their skills, which is what we think will be the future. And I'm always drawn back to this quote that I'll share in just a moment, but people describe this as this Promethean moment. You know, it's a gift to the world, but will it help, or will it burn us down? I think it will help, and this is the quote that I wanted to conclude the talk with, which is that ultimately, this is the famous quote about the secret to caring for the patient is to care for the patient, and I do believe ultimately And fundamentally, what we do is a human skill, which is to care and to be there. And I think that will never change. I think these tools will help us do this better, and will help us help others do this better. So I am left with a very optimistic view of where we are with AI and how it's going to evolve. And I do think it will take ownership from us to make sure that we manage it in the way that we aspire for it to be implemented. So I'll stop there. Thank you again for having me. I think that's it. I'm happy to take any questions.
Hi, Jeff Carson.
Yeah,
That
nice to
was
see you.
great. In a lot of your examples, it's like, how do you establish a gold standard? Because you're trying to take this data to predict people to do something outstanding, but actually knowing what the right gold standard is really hard. If you're trying to diagnose this with PE, well, if you got a pulmonary angiogram or a CTA, you know, then you have evidence for it. But you're trying to do this, your outcomes are much more challenging. And your insulin example, it may be that the individual cases, the mix of insulins may not make sense for some of those cases, yet, you know, that you're trying to push people to a particular standard. And that's just one example. But I just think whatever you're trying to predict, understanding what the gold standard is would be very difficult in many situations.
Yeah, I think that's a great point. And
Repeat the question.
yeah, sure. So the question was about, you know, how do we know what the gold standard is for these? Because we're assessing, I guess, an outcome that we're saying this is what should happen. And the insulin example, it may be for an individual patient that isn't what should happen, and we're assessing for some standardized algorithm. And I think that's a very good point. I would say two things. The pilots that I showed you and those that I've seen come out recently are the gold standard has been experts basically coming together and saying this is what we wish for people to have based on my interpretation of the data, based on practice guidelines, based on what we at this hospital have decided that we want. And if we can, and that may or may not be the best or the right answer, but it's what's being used typically as the gold standard. And what I would say, and I think this is true for a lot of the criticisms of AI, is that we have to compare that to what we're doing now. So I think if we have here, let's just say at this hospital, we expect people with this condition to be treated in this particular way. We're using that as gold standard. We just have a hard time assessing against that in the current model. So we're saying, okay, let's keep it there, but now we have a more effective way at least comparing against that and assessing against that. I think your point about how do you get down to individuals and see if it was right for them or not, and you're right, we don't know, but you could imagine that you could use these data to find those outliers and then decide, adjudicate them and say that was appropriate or that wasn't appropriate. So I think you could still do those things. My view is that without these data, we can't ever get to the point that we're going to have assessment against any gold standard. And we're just trying to, right now, most of these are duplicating a gold standard that we use today. We're just unable to assess against.
Hi, thanks for this talk. Mike Kelly from Pediatrics. An RSV can vary based on the environment that you're in. It doesn't vary so much. But my question is that, so you've talked a lot about the assessment, how this would really enhance or accelerate the assessment we have, which is like read more, work harder. So my question though is, what do you see easier to change, that we will be able to enact this and truly meet the promise of competency-based education? Or are we going to be able to change the funding nature of GME so that we can actually do that?
So the question is, I want to make sure I clarify the question, but you might need the microphone. So will we be able to enact this and hopefully use these tools to accelerate implementation of competency-based medical education? Or, I didn't get the second part.
Sorry, and actually be able to change how GME is financed, because that is going to interfere with all this.
Okay. And change financing for GME, which will help all of this. Finance for GME, I think, is obviously, as you know, very challenging to think about how to change. I will say that these tools, as I've seen them start to develop and be implemented, they are, as you can imagine, being implemented in high resource settings. with high-resource institutions that have the funding to be able to create pilots like this and have the resources to pour into it. So one of the parallel efforts that's occurring is thinking about how do you democratize this. So this gets a little bit to the how do you fund this work. So how might you democratize these technologies? Because the default future would be, if it starts in highly resourced institutions, that it will in 10 years only be accessible to highly resourced institutions and patients that therefore get care there, which would only increase the disparity. And this is very similar to the technology gaps that we've heard about outside of AI in education and in other parts of the economy. So the democratization is being pursued not by trying to change GME financing, which would be good for lots of different reasons, but by creating principles and standards for this work so that whatever is created in a high-resourced institution can be taken more easily, not easily, but more easily, and replicated and scaled in different settings. And so there's examples of that already happening. And but without principles and standards for this work, that can't happen. And that just takes us back to the experience that we had with electronic medical records where they're not interoperable. And it took tremendous effort to get us even where we are today. So there's an effort now, there's a group named Ubiquitous, which some of you may be familiar with, which is out of the AAMC, that does the technology side and data side of medical education. So with them, we're actually creating those principal standards are being developed right now. So that's the idea. So we can't fix necessarily the funding that will help promote implementation of this. We can hopefully make it easier for technologies that are developed, systems that are developed to be implemented in different settings. And then Brian mentioned the grants. We just gave out $12 million of grants in this from the American Medical Association. And one of the requirements for that was to show that it can be replicated in a lower resource setting. So we're recognizing that what you're saying is a very important thing to address early. It's hard to guarantee funding for everybody, but we can try to make the barriers lower.
Thanks so much, Sanjay. I'm going to ask you two questions, if I can, at the either extreme. We had a conversation last night about from undergraduate into medical school and the 3-year medical school, talking about sort of maturity and learning. What opportunities do we have there to really individualize, to figure out, gets a little bit to get to non-standard lengths, right? At some point, if someone just competent, they should graduate and move on. So that's the first question.
Okay, yeah. So I believe the future of medical education, GME included, is competency-based time variable education. And that's really hard for lots of reasons. It's easier in medical school because there's not a workforce dependency on medical students. And so therefore that's why the 3-year experiment is I think accelerating, is because we can have them leave medical school and enter GME. Now, even there, you could argue, okay, they all leave on July 1st, right? So there's still even, because some students are ready before that, but let's just, I think that it can happen easier there. In GME, and I'll get to the assessment part, the GME, it's much harder. And there's a number of experiments that are done. So the one experiment that I can talk about, because I know it well, is one that we funded from the AMA. And this was part of a time variable GME. And Mass General Brigham decided that they were going to pursue this. And they had 14 specialties, 14 that wanted to pursue time variable GME. And as they got into it, barrier after barrier, that whittled down to one. And it was pathology. Pathology actually went through it. They did time variable. There are differences, right, in the clinical structure of and workforce of pathologists compared to some other specialties. But the barriers that they broke were not just within MGB, they had to get licensure. So the state licensing agency, the state medical board had to make changes in their policy. The American Board of Pathology had to make changes in who can be eligible for a certification exam. So these are all things that have to change, that have to become flexible, and they did that. Now that they've done that, it's happening in 2 other specialties. So it's started. So the gates are open. So I think it's possible. And the hardest part there is bureaucracy, which I just talked about. But the hardest part, I think, from those that are operating these systems is assessment. Because you have to be able to defend the competency reliably of each individual. And I think in the models that we have without precision education, that's really hard to do. I think you need these types of data to be able to have a defensible competency assessment for anyone. That includes medical students, but it really includes GME.
The second question is I'm finally, after taking my boards 3 times, I have switched to the knowledge assessments, right? Are they using AI-based sort of competency in those? Isn't that an opportunity to say, maybe I'm already very good at managing, metabolic things, but, rheumatology, they should just keep hammering me with those questions.
Yeah.
Is that being done, or is that being considered at the sort of CME level?
Yeah, no, that's being considered. It hasn't, as far as I know, it hasn't been done. But the last example that I shared was Dr. Pugh in Stanford doing precision education system for surgery, for procedures, I should say. So one of our grants that we just granted was to Stanford along with the American Board of Medical Specialties. So it's a combined grant with the boards to say, and the American Board of Surgery. And so they're looking at how might you integrate these types of assessments into certification so that you eliminate the high stakes certification, but you create longitudinal competency-based assessments that are then targeted to each individual that you need to learn this and you need to learn that, but then you have a reliable assessment model for us to act on that. And so that's why I say 100% it's happening because the ABMS is part of its grant. That's it.
Okay, we'll do one more question. I just want to ask, there's a couple of questions in the chat, but I don't think we'll get to everything. One of the things from your talk, you talked about giving agency back to the learners. And a lot of these interventions are at very high resource institutions. We have a room full of residents here. What are some things now that they might be able to do to contribute to their own precision education?
Yeah, I mean, you can help us because you guys, you're all probably closer to it than most of the faculty that are there. I think that the open evidence is the obvious example, I think, of experimenting with precision education. The difference is that it's not knowing enough about you right now. But I think what you can do is ask your institution if there are data that can be dashboarded to you. I'm not sure if open evidence has that type of ability to share data back with you yet. But I think that's another one that, to me, describes how this is shifting under our feet. As I understand it today, open evidence, more than half the physicians in the US are using open evidence for clinical decision making. And they captured, I forgot the exact metric, the same number of physicians in, I think, 6 months that it took doximity to capture in over 10 years. So again, just demonstrating that these things are happening and they're taking off. So I think from a resident perspective, to recognize you're closer to it than we are. And you're also at a point where it's a formative moment for you. So this will become part of your practice for sure. So I would say, A, help us learn how to use these more effectively, but then help us also think about what type of data would be useful for you. And I think, again, open evidence is one example. Different institutions may have different dashboards that you have access to. But starting to use those and starting to ask questions and let people know what would be more useful for you, I think that's what's going to drive. This is where I talk about ownership. I mean, the ownership of these innovations is really in the hands of the residents and the medical students, not really in our hands. You know better than us what will be helpful.
Thank you.
Yeah, thank you.
What is like a very silly question? I was a critical care rotation here.
Oh,
And one of the issues that's come up recently is some of the non-faculty educators at Texas and some of the other units are telling me that having medical students on their team is up to 30%. That was excellent. Yeah, nice to see that. Up to 30% longer for their day, and they're not getting any sort of relief from any sort of standpoint for having learners and various learners. I have an out-of-the-box question. Is there anything out there to say staggering.
I feel like we just didn't have time. I'll text Dana.
That I think is the raw